Good morning, everybody. We are going to have a very interesting talk. It's on a totally new topic, and I just uh, learned about it yesterday from him, and it's very exciting. It's about uh, eyes and eye movements and balance in Parkinson's. How Parkinson patients do not understand they are losing balance, how they have lots of visual problems. So we are going to see this is actually a lot of experimental work Aasef is doing on this, and he will take us through it. Thank you, Aasef. Go ahead.
Yeah. So thank you, Dr. Katari. It's a pleasure again to be here and speak on a little bit different topic today. Although it still involves eye movement, it still involves vestibular function, still involves balance, but it still keeps us in the clinic, but it still takes us out of the clinic a little bit to dive into this very important topic of why Parkinson patients fall, because it's a big problem, as you will see in next few slides, and it's very important for us to understand that why that happens. And that's actually has been a big mission nowadays, and as many of you may know, that federal government has put a separate pot of money aside, which has what we call program announcements. The big mission of the federal government is to address falls, and especially in Parkinson, because it's very common, and I will show you some statistics on that too. So before we move on, I want to give you a little outline of how we will approach to the discussion today. So we will first understand the gravity of rather unappreciated problems in Parkinson. One is vision, and second is balance dysfunction. Then the next, what we will do is we will then take one thing first. So we will look into the visual function, and we will try to understand which aspects of the visual function is affected in patients who have Parkinson's disease. And then we will discuss what we can really do for their treatment. Now, many of us know that there's not much we can do, except we have a novel focus now to treat these, which includes a very cutting-edge treatment for Parkinson, which involves neuromodulation, deep brain stimulation. And then we will look into which aspect of balance functions are affected in Parkinson's disease, and what we can do to improve the balance function in Parkinson's. So before we go into everything, I want to first go over some basics. What really regulates balance of our body? So first of all, we need three sensations, right? So we need vestibular sensation, which is our inner ear. Then we need somatosensory, and we need vision. And all these three areas of our senses, they integrate centrally in the brain. And that multisensory integration is critical in defining accurate balance, accurate perception of your balance. And basal ganglia tend to play a fundamentally critical role in multisensory interactions. Especially, it influences indirectly many areas of our brain, and that influence is very important for putting all these different senses together in a right context, so that we make the best out of it. And that is something is basis for a lot of effects that you will see today, how different modalities like deep brain stimulation affects these functions. And of course, it's basal ganglia is not the only thing which is important, right? So the coordination of these senses are also done by the brainstem, cerebellum, and then ultimately it goes to the cortex. And these are like more fundamentally important areas of our brain, which puts isolated senses like vestibular, balance, or somatosensory into right coordinates, so that in other words, it prepares the meal for basal ganglia to put together a big dish, right? So it's just a very essential component of the overall picture is put together by cerebellum, brainstem, and even peripheral sensors, which includes eyes and proprioceptors and also the vestibular end organs. So speaking of falls, we are all very much used to looking at the world map like that for COVID. But if you look at the falls map actually is not too different, except you can see India actually is pretty high in rate of falls, which is not in COVID. But in any case, falls is very important, very big problem in world, and that is cause of many, many morbidities and mortalities. You don't have to have Parkinson to fall. Anybody can fall. But if you put that fall map next to Parkinson, and if you compare, so if you look at the United States, so the rate of Parkinson in the United States is pretty high, as you can see, and falls in the United States is also high. Likewise in South America, for example, it's pretty high. In Europe, it's quite comparable. Likewise in Australia. So what I'm trying to say is that incidence of Parkinson's and fall actually go neck to neck, side to side. And that stays with the fact that about 10 million people worldwide suffer from Parkinson's disease. So it's quite common, very common. And I often tell my patients that if you live 100 years, then everybody gets Alzheimer's disease. And if you live 110 years, then everybody will get Parkinson's disease. It's just a matter of some people get it sooner than later. And if you get it a little sooner, then you end up in my clinic to see me for Parkinson's. So it's very common. Unfortunately, approximately 70% of Parkinson patients fall. What I call frequently, they fall at least once a month or twice a month. And it's quite common in my Parkinson patients. Now, the most frustrating thing about the falls is that we really don't have good treatments for the fall. Some patients have falls which are responsive to the dopaminergic system, but very frequently we find falls which are not responsive to the dopamine system. And when we implant them with things like DBS, sometimes their balance functions get better, sometimes it gets worse, and sometimes it doesn't matter. So we want to first understand what really causes falls in Parkinson's disease. And then once we understand what causes falls in Parkinson's disease, then we can take that basic mechanistic underpinnings of falls, and then we can put them into right perspective to treat falls. So it's very important to understand what causes falls. So, and of course, there are some consequences of falls. I don't have to tell you that, but it can cause broken bones. It can cause intracranial bleed, especially in our older patients who already have cortical atrophy and they already have bridging veins. They're more likely to get subdurals. And of course, social fear, like people won't go out of the home, people won't leave their wheelchair, people won't go to parties because they have fear, they're worried that they will fall. So if we somehow can come up with really good treatment for prevention of fall, you can actually make a significant impact on your patient's life. And that's the mission of my career, and that's the mission of my research. So coming back to a fundamental question, what really causes fall in patients with Parkinson's disease? So of course, we all know that Parkinson patients have tremor, they have dyskinesias, they have hyperkinetic movement disorder like dystonias. What these movement disorders do is they can cause postural perturbations in these patients. And then when you put together with impaired muscle tone, decreased reaction time, and difficulty in navigate their visual environment and the special navigation like a balance function, when you put that together, that actually makes a just perfect environment for this patient to fall. What we can do with medications, we can fix their tremor, we can fix their dyskinesias, maybe we can fix their dystonias. We can do the same thing with treatments like DBS, which can help with postural perturbation or even muscle tone. but we really don't have the treatment for two key players, which is visual navigation impairment and special navigation impairment, which also has important influence on fall. So first we will talk about the visual navigation impairment. So visual dysfunction can create two major problems. So these patients actually end up seeing double or blurred, and they don't look at the right place at the right time. Okay, so we'll first talk about these two phenomenologies in visual dysfunction, which is blurred and double vision. Now you will ask, like, why in the world do I care about the visual symptoms? They're not that common. My Parkinson's patients don't come and tell me that I have nystagmus, or they don't tell me that I have strabismus. So many of you may have noticed that in recent volume of Neurology on March 11, 2020, not even a month ago, there was a publication which came from Europe. And then there was immediate press release on March the 20th in American Academy of Neurology about this, because it was a major splash. What they did is they studied more than 800 patients who had Parkinson's disease, and they sorted out their visual symptoms. You know what they found? They found about 50% of these patients had blurred vision. Now I say, fine, blurred vision. They don't blink too much. They have dry eyes. They get blurred vision. Fine, yeah, that's true, but that's not the only cause. About 25% of people had difficulty in reading. What these people told us, or told the authors, that, you know, when I try to look around, that's okay, but when I'm trying to look at the computer, I see blurred. When I try to read something, I have difficulty in reading. They say that I have difficulty in moving my eye from one place to the other. They have difficulty in moving their gaze, in other words. About 20% of the people said that I cannot perceive depth. So, you know, depth perception is a very important feature, which is accomplished by coordination of two eye movements, binocularity, right, for vergence. And about 20% of Parkinson patients, 1 in 5, said that they had difficulty with that. And approximately 20% of the patients said that they also had double vision, what we call diplopia, which is seen in strabismus. So what is a common feature of all these four main major problems, which are considered now common visual symptoms in Parkinson? Impaired eye alignment. So this is the area of our focus. What kind of impairment do we see in eye alignment, and what we can do to treat it? So we see two forms of impairment in eye alignment. One is the strabismus, which is what we call squint, or cross-eyed, right? One eye is looking on one side and the other eye is looking straight. It can be either to the side, which is exotropia, or it goes in, which is esotropia, right? And when it is acquired in adulthood, it can cause double vision, as approximately 20% of my Parkinson patients tells me that, right? And second is convergence insufficiency. It's a cliche in movement disorders, right? We say, oh, Parkinson, convergence insufficiency, we know that. What that means is when they look from far to near, they don't have ability to converge their eye normally. And as a result, they're unable to read when they look at the computer screen, or they are unable to read when they look at the book. And this is actually a major problem in our patients with Parkinson's disease. Now imagine today, nowadays, everybody relies on iPhone or you know, smartphones for everything. Now your Parkinson patient has to look at the iPhone to do many important things in the day-to-day life. And if they have convergence insufficiency, it's a major challenge. It's a major problem in navigating in activity of their daily living, right? So it's a major problem. Now, I want to give you a little view of Taj. And I want to kind of like give you a little perspective that what happens if you have double vision or blurred vision or ocular misalignment as you are enjoying this real nice picture of Taj, right? So your left eye and your right eye both are looking straight ahead. Of course, I'm sitting in front of the computer, so I don't really have a good view of my Taj, right? But if you look at the Taj in real life in 3 dimensions, what happens, your left eye and your right eye gets slightly different image of thought, right? And your brain fuses those two slightly disparate image, and it puts together a nice 3D view of a gorgeous monument, right? Now what happens, let's say if we have some problem and if your right eye is tilted or turned on one direction, then what happens is that it goes out of that normal fusional area of the brain. Now you are no longer able to make a 3D view of a Taj, but instead it looks blurred like this. Now it all depends on how much of the misalignment you have. If it is a lot of misalignment, then in fact you see more than one. You see two Taj Mahals like next to each other, or up and down, depends which way the eyes have turned. Or if it is a little bit misalignment, then you will see a blurry vision. So this creates a major problem in navigating your day-to-day life. So how this then cause falls, right? So one, it clearly causes double vision, and when it causes double vision, you are not going to have a clear view of your image, of your environment. It is going to make you off balance and you're going to fall. And the second is, of course, you don't have a perceptive depth. So you don't know how deep your tasks are. So you cannot really execute your movements of your body appropriately. And as a result, people may lose balance and they fall. So it's very important to correct your double vision, to correct the depth perception problem, which we know that it's a very, very common in Parkinson patients. And we have to have a way to treat that. In other words, we are really desperately looking for a way to treat it. So of course, we think of drugs. There are some papers out there which looked at the pharmacotherapy and looking at the pharmacotherapy and strabismus in Parkinson, pharmacotherapy and convergence insufficiency in Parkinson. And the literature is there, but it's quite mixed, and there's not a very clear idea that which drug can make visual function better. So it's basically not very useful. Eye muscle surgery, I often tell my patients that, if you have strabismus because of neurodegenerative disorder, I recommend against getting an eye muscle surgery because it's a neurodegenerative disorder. So it's kind of a moving target, right? So you have a different level of disability now than 3, 5, 6 months later. So if you get eye muscle surgery done, it's not going to give you a benefit in a longer term. It may make things even worse. So it's not a very good idea. Serendipitously, what we find is when we do neuromodulation with something called deep brain stimulation, we actually see a substantial improvement in some patients, although not in all. So what we want to do now is we want to study how we can do neuromodulation most effectively, such that we can not only provide them the benefit for a routine Parkinson symptoms, but we can also offer the treatment for visual function in using the same electrode location, using the same methodology. So before we go into there, for some of our colleagues, I would like to give a little preview of neuromodulation. We also call functional electrical stimulation or deep brain stimulation. So here a little a video we put together, which gives us a little preview of what is deep brain stimulation. So I'm going to play it.
Neuromodulation, or functional electrical stimulation, restores or blocks damaged nerve activity. All body functions are controlled by the nervous system. FES uses artificial low-level electrical impulses applied to the nervous system to replace or block the damaged neurons and signals, restoring lost function. Think of neuromodulation by FES like a faucet, able to be turned on so that the impulse can flow, slow down, be intermittent, or even stop. FES can aid those with neurological disorders such as Parkinson's disease by way of deep brain stimulation, or DBS. Deep brain stimulation blocks signals from targeted areas of the brain to reduce tremors and enable individuals to walk more normally.
So this was a little preview about what deep brain stimulation does, some basics of deep brain stimulation. And of course, as you will see in some slides, that it is used to treat tremor, it's used to treat rigidity in Parkinson's disease. We can improve their bradykinesia, hypokinesia. We can also improve sometimes their gait, although it is not always the case. But what we are interested in that how we can use deep brain stimulation even further. So this is actually one of my patients who told us a little story about how what deep brain stimulation did for him for his routine Parkinson, and I would like to share this with you before we go on for more novel applications.
Well, I could while away the hours conversing with the flowers, consulting with the rain. I could stop my hands from jerking, I could keep my brain on working, so I can use my brain.
Sir, if there is an audio to the video, I would request you to please increase the volume of your device.
She came across the DBS surgery plan some time ago.
Is it good?
Yes.
I just personally had to be ready mentally, physically, spiritually to do that. And it took me, well, almost eight years before I had had enough. When we walked out of the hospital to the car in the parking lot, we held hands for the first time in 8 years. There is no cure for Parkinson's. We all know that. But again, the idea is to add some quality to your life. And DBS surgery has done that for me.
So it's actually very it's very dramatic, and it's very heartwarming for many patients when we implant them with DBS, and people cry when in the office, in the OR room, when they start moving their arms. And now we do like hundreds and hundreds of surgeries like this, and a lot of thousands of patients like Steve here are benefited with deep brain stimulation, but there are clearly limitations, right? So while we can have a real good grip on tremor or muscle tone or hypokinesia, bradykinesia with DBS, we still don't know how we can utilize this technology to make their balance function and their visual function better, right? And that's where my story begins. So we are looking at the application of DBS for treatment of, for example, double vision. So what we have a facility to precisely measure the eye movements and to change the DBS parameters to study the eye function. And I would like to give you a little preview of what we do for eye movement measurements before I show you some interesting results. I work with Parkinson's patients, and the novel idea is to come up with new strategies to prevent falls. So what we are interested in is we are looking at certain signature psychophysical parameters of how patients with Parkinson's disease perceive the balance.
We plan to investigate the effects of deep brain stimulation on eye misalignment and convergence. Currently, the challenge is the lack of collaboration.
Can the volume go up higher, Aasef?
The collaborative
Yeah, this is the most I can have.
Okay.
The central mechanisms of strabismus, but it will also help us understand the effect of visual dysfunction in patients with Parkinson's.
That's better.
And how visual function ties into freezing of gait, veering, and balance issues.
It was clear, right? the volume.
Yes.
So let me just tell people what is here. Actually, this is a good view. So what happens is patient sits here, and we have like a occluder. Actually, now we have a computer operated occluder, so we can look at each eye separately. And there is a high resolution camera which is attached here, which measures the position of two eyes with a very high precision and with a very high sampling rate. So what we ask people to do, for example, here is patient with Parkinson is sitting in front of a screen, and there is a red dot which appears here. So the patient is supposed to view this dot, and as patient is viewing the dot, we are measuring the patient's eye movements. So here I'm going to show you an example of Parkinson patient with deep brain stimulation off. And what we will plot is vertical position of the eyes on this axis and the horizontal eye position on this axis as the patient is viewing this dot. So what happens is that when patient is viewing the dot, the left eye is actually looking at the dot, as you can see here, but the right eye is turned to the side and its position is moved to the side. So what happens as a result, the same patient will have a percept of more than one, like it's either the dot would be blurred or it would be double. It will give diplopia, right? So what happens when we turn the DBS off in this patient? There is a very dramatic response. And what we see is that the two eyes are now all of a sudden aligned and dot would be fused. So deep brain stimulation, we are now finding that very frequently, if it is strategically placed and strategically stimulated in subthalamic nucleus, we are able to treat double vision in patients who have Parkinson. And I must say that we are not implanting a separate electrode for the double vision. This is the same electrode which we are utilizing to treat the Parkinsonian motor symptoms, but we can program it in a different ways to have more out of it, to get the best response out of it and treat visual functions as well. So that was one aspect. Now, the second problem that Parkinson patient gets is that they're not looking at the right place. So what does that mean? So I want you to look at this kitchen counter and look for the loaf of the bread. And I'll give you 5 seconds. So many of you may have located the loaf of the bread, and then when I measure the eye movements of a healthy people who are asked to view the same image while I'm measuring their eye movements using the laboratory technology, what we find out is that a lot of times the patients span their gaze over here. As you can see, the red color here compared to on the fridge or on the counter or on the bowl. So healthy people actually find the loaf of bread pretty rapidly and without having any major abnormality. Now, when I ask the same task to the Parkinson patient to find the loaf of bread, what happens is very interesting phenomenon. So Parkinson patient actually looks at certain locations like fridge or here or in the bowl, but then they get stuck onto this toaster, which actually makes a very interesting idea that, you know, we all know that we put loaf of bread in toaster ovens. So our patients are not wrong. They are expected to find them in toaster oven. They go there, it's not there. So they move their eyes back, but then they keep going back to the place where they have previously formed memories, what we call priors, that loaf of bread, go to the toaster oven. Although it's not there, go to toaster oven. So in other words, what their eyes see is only what their mind is prepared to comprehend, right? Their mind is prepared to comprehend that bread is supposed to be in the toaster oven, and this keep going there. Although they don't learn, they don't create new priors, so to speak, that, oh, bread is not there, let's go somewhere else. They don't have that ability. And that is very interesting. We will get into a little bit of details of it, why that really happens and how we can help with this. And if they have this problem, and as they're navigating in space, then they can't get to the right object which is pertinent at the given time. And as a result, they may lose their executive ability to walk, and they may lose balance, or they may even fall. So that is also very important. So let's go back a step and let's talk about what happens really when you are viewing anything, computer screen, or when you're looking at a nice portrait or a picture. So what happens is you imagine your eye should really be still when you are viewing, but actually they're not still. What you see is you see miniature forms of eye movements that are present, which are during even fixation. We call it microsaccades or many other type of fixational eye movements. And they are the result, as a result, the retinal image that keeps falling on different foveal photoreceptors. So these eye movements are so small that it keeps moving the focus of the image from one foveal photoreceptor to the other, not too far from it. So as a result, they still capture the image, but they don't keep stimulating the same photoreceptor. And that is fundamentally important, super duper critical, because what happens is if you keep stimulating one photoreceptor constantly, then it adapts. And when it adapts, it stops transmitting signal, and you can get functional blindness. So these tiny eye movements that you make to capture the image, which is important, that you really have to make multiple eye movement. And I tried to make a little animation here. So what you see here is this is your rods, and these are photoreceptors. And each time your eyes are moving, one photoreceptor is lighting up, but as you can see, it kind of like goes away. In other words, it saturates. So in order to keep the image in this whole area, your brain is moving the eyes in little steps so that you are keeping your different photoreceptor occupied. At the same time, you are seeing the image very clearly. So what type of these movements you make? So I want you to take a look at this picture. And as you're looking at this little painting of dogs, what you are seeing, these black lines. What I'm plotting here is the position of a normal person's eye when that normal person is looking at these pictures of dog, right? So it's going to be, your eyes are going from one place to the other, capturing the image. And what you are seeing, what you're doing while you look at that picture, is you make some kind of exploratory eye movement, what we call saccades, which is to search and explore, like a big trajectories like this, right? Or you make little fixational eye movement, which is microsaccade or miniature eye movement. And this miniature eye movement actually take in the picture. It absorbs the dog's face, or it absorbs what written on the board here and whatnot. So it's important to capture the abstract of the picture. It's more or less a cognitive domain, while bigger eye movements, which is saccades, they are more exploratory in their nature. So both are important. Actually, both fall into continuum, and we won't go into details of that, but both also follow very similar mechanistic underpinnings also. So fixational eye movements are not only microsaccades, which are fixational saccades, which happen actually every second or twice every second, but it can also you can also see what we call ocular microtremor. I must tell you that this is not actual tremor that many people say in eyes, which actually is very controversial. This microtremor is, it's so small fixational oscillations that are not visible with any kind of ophthalmoscopy or any kind of routine measurement equipments that we have. It is only measurable with a very specialized invasive technique that had been used in past. And as a result, since it is invasive, nobody really studies ocular microtremor. So most of the literature that you see contemporary, we don't see much about microtremor. So I'm not going to talk much about microtremor. We'll focus mostly on the microsaccades. And of course, we also see drifts. So your eyes are not always steady. They always have a very slow, about 2 degrees or less per second of movement between two microsaccades, and they're called drifts. So between microsaccades, ocular microtremor, and drifts, your eyes are always in constant motion. And although you think that they are fixated, and that's why we call these eye movements fixational eye movements. And they are important because you want to make sure that your retina is occupied. It is not stationary, and your rod cells, you are constantly changing the location. So you don't adapt them and you prevent functional blindness. So this fixational eye movement are critical, and they are abnormal in Parkinson. They are excessive, they are large, and they're abnormally programmed. And when that happens, what you will see, when we ask that guy with Parkinson to look for the bread and kitchen counter, that patient actually made 118 microsaccades compared to 17 which were made by a healthy subject. So what happens is there is a problem with the cognitive domain. So they make so many microsaccades back and forth. They are not capturing the image in most appropriate way, and they're not putting that in the right context to take the gaze away from something which is believed by the brain and their eyes are seeing, right? So they're not using, they're not generating their new priors. They're still keep using their old priors, and they're driving their microsaccades from their old experience, but they're not generating the new experience. As a result, they keep making multiple searching eye movements like microsaccades, and they're not able to do that. In other words, there is fundamental malprogramming, and that fundamental malprogramming is then seen in form of excessive microsaccades. DBS does miracle here too. So what happens is now we ask people with Parkinson to find a object which is somewhere, and healthy people made about 11 saccades to find that object which was in the oven. Actually, Parkinson patient did pretty good job too. They only made 19 microsaccades. In other words, what they can do is actually they can create a DBS improves that malprogramming, and then they improve that cognitive domain, and then they steer the scanning eye movements like microsaccades and saccades in such a way that brain can efficiently find the object that they want to see, which is actually quite fascinating. And we never imagined that DBS can do that. So to summarize, microsaccades are needed in right amount, not too little or not too few, not too many. We just need them in right amount, and they need to be rightly programmed in order to get to where we want to get to. And again, DBS can improve that abnormality. Now, I want to show you this video, and a lot of you may probably know what this is. So what we call it square wave jerks. And square wave jerks is nothing, but it's an elder brother of microsaccades. So what happens is microsaccades form a continuum with square wave saccadic oscillations or square wave jerks. Whenever microsaccades get larger than 1 degree or 2 degrees, your eyes go farther away from a target of interest. And what happens is your brain makes another microsaccades, which is same amplitude, to go back, and it becomes square wave jerks. So here I'm giving an example of a normal subject making fewer microsaccades like here and fewer square wave jerks. This is a Parkinson patient who is making much more number of microsaccades compared to the healthy subjects, as you can see. So each tiny little jerky vertical deflection in this line here is your microsaccade, and otherwise this is your gaze holding. The Parkinson patients have a lot of it. Now, if we compare them with PSP, who we know have square wave jerks, they have much larger amplitudes of these movements, and they are much frequent. So what my mentor, John Lee, I got this figure from, showed actually is that square wave jerks are continuum of microsaccades, and they are actually, so if microsaccades at this level in Parkinson or in control, it's right here in Parkinson, and it's right here in PSP. So they are just incremental. And not only Parkinson and PSP, but if you look at corticobasal syndrome, we also see much larger amplitudes of microsaccades over here, or even in MSA, we see tremendous numbers of these microsaccades and square waves. So these fixational eye movements are actually quite fundamentally interesting and important in various forms of Parkinsonian syndromes. It's not just exclusive for Parkinson's disease. Now, third, why do Parkinson patients fall? So we talked about the visual dysfunction, right? Seeing double, not looking at right place. Second important problem is the balance problem, right? So Parkinson patients have, I must say, they have normal vestibulo-ocular reflex, because whenever you think of the vestibular function, you always think of the vestibulo-ocular reflex, right? And they are normal up front. However, they have a big problem. These people cannot normally perceive their own motion. So vestibular function has two major arms. So one arm is your vestibulo-ocular reflex, but the very similar fundamental mechanistic underpinnings are there to perceive motion. And their perceived motion actually goes further from the cerebellum to the thalamus, and thalamus to cerebral cortex in medial superior temporal, parieto-occipital junction and parieto-temporal junction in area MT and MST in the brain, in cortex. This area is important, where your vision and your vestibular systems get together, and it tells your brain that which way you are actually moving, your perception of your motion, your perception of your heading. It's very important. And all these areas are under direct influence from the basal ganglia, either via cerebellum, either via the pathways from the cerebellum, or directly to the cortex. Either way, when you have problems in the basal ganglia, you can have problem in spatial navigation. So we actually found that in a very serendipitous observation, and it actually changed the way we view the vestibular signal processing in the central nervous system. And it actually happened when I was in training. I was with my mentor, Malin DeLong, whose picture I show here. And on the left of that, I'm showing you the surgical field, because this discovery actually happened when Malin and I were in the OR trying to navigate a patient's subthalamic nucleus, trying to find the right location to implant for Parkinson's disease. And as part of that surgery, what we do is we go to different areas of subthalamic nucleus, stimulate that, make sure that it is not creating any problem, making sure that we are finding right type of neurons, and making sure that we are seeing some right improvement that we want to see. As we were doing that in the OR, these patients are alert because this is an alert surgery. So patient told me that I am actually feeling that there is intense spinning in the brain. We kind of discounted that. It was reproducible spinning, but we kind of discounted that. The same patient came again to the clinic, and when I was programming him, and whenever I was stimulating him, one of the DBS contacts, so I will show that to you in a minute, he tells me that he's feeling spinning, which was very interesting. And it was dependent on the amount of electricity I give. I give him more electricity, he feels more spinning. If I give him less electricity, he feels less spinning. And when I give no electricity, he doesn't feel any spinning, which was very interesting. Then 4 more patients came with something similar. What happened is whenever I stimulate the contact number 1, of their DBS, they were having this problem. So we modeled these people's brains. So what you are seeing here, this is your red nucleus. This is the sagittal section of the brain. Here is your subthalamic nucleus, and this is substantia nigra. And this is the electrode which normally we don't stimulate. We generally go over here, but as mapping, we do that. So whenever I stimulate this electrode, patients were getting spinning. What you see is this electrode is quite proximity to these purple fibers. You know what these purple fibers are? These fibers are cerebellothalamic fibers, and the cerebellothalamic fibers are the fibers which carry the vestibulothalamic tract. So what vestibulothalamic tract does, it takes the balance perception signal up to the brain, to the cerebral cortex via thalamus, and it tells your brain which way you are moving. So it was very interesting. Whenever I stimulate the electrode which was closest to the vestibulothalamic fiber, patients start spinning. So that actually gave me an idea that, if I can really create a problem for patient by stimulating the vestibulothalamic fibers, then actually I can use a counterintuitive approach, and I can modulate the vestibulothalamic fibers to treat balance in patients with Parkinson, because that's a major problem. And that eventually became a substantial part of my career. So what we do now is we try to study the perception of motion in Parkinson patients, and how we use DBS, how we can utilize DBS to improve the perception of motion. In other words, to improve their balance function. So what we do is we have a unique motion delivery system where patients sit on this little platform. What platform can do is it can move the patient in whichever way we want. And patient is sitting on a chair on top of the platform. The head is stabilized. They are wearing a blindfold. So basically this is en bloc motion, and they can report to us which way they are moving. And I will show you this little video because this platform is very unique. It's actually utilized by space agencies like NASA to train their astronaut. But what my mentor, John Lee, did is he used this platform, and now it's in our lab to study vestibular function in patients with balance disorder. And we utilize that to study Parkinson and balance. Hexapod is very unique motion delivery system. It's meant for training astronauts by NASA. Somebody in our field came up with a clever idea that they can use this system to move humans to test self. So what happens is when the platform moves, people report which way they are moving. And what we do is we stimulate different parts of the subthalamic nucleus in their brain utilizing DBS, and we find the areas of subthalamic nucleus which gives you the best response in terms of motion perception. And what we find is actually improves it. So from our result, what we found is Parkinson patients normally, these people they're unable to precisely perceive their motion. They cannot tell in which direction they are moving, whether they are going to the right or they are going to the left. And a lot of our patients sometimes veer on one side. And as they walk and veer on one side, they may lose balance, and as a result, they may fall. And what happens is that when there is an abnormal basal ganglia activity, it affects your central vestibular system, and it creates problem in balance and motion perception. And what we do with the DBS is we find the right area within the basal ganglia, which changes this abnormal output from the basal ganglia, which is destined towards the central vestibular system, and it improves the balance function in some of our patients. To wrap up, Parkinson's disease patients fall frequently. That is because they have problems both in the visual and the balance system. The visual symptoms are extremely common in Parkinson patient. The big problem these people get is blurred vision, double vision because of the convergence insufficiency or strabismus. the abnormal gazing behavior, including fixation saccades, they are excessive, inaccurate, and they are malprogrammed. And they also have problems in perceiving their motion because of the vestibular system. And all of the above we can handle very well with strategically programmed or placed deep brain stimulator in the subthalamic nucleus. Of course, this DBS ideas are currently we are investigating. There is much more work for us to do, but we are very hopeful that in near future we will have very strategic locations within the STN, which will help us to steer the currents through DBS, not only to treat the motor symptoms, tremor and tone, but also simultaneously address their visual function and also their balance impairment. And we are very hopeful by doing that, our patients will have substantially improved quality of life. And with that, I want to thank you all, and I want to thank my funding agencies who have made it possible for us to do all the work that we do, and my lab members and my collaborators and mentors. Ready for questions.
Thank you. Rishikesh, will you take the questions?
Yes, I can. Aasef, wonderful talk and very simplified, very important topic. We often used to neglect this part. And we all like this slide very much. It was a very simple slide, less words and right information. So thank you very much for that.
Thank you.
And now taking the questions, we have some questions. But before I start the question, I would say that you showed that map of world, where you showed that India has high risk of fall, despite we all know that low prevalence of Parkinson disease as compared to Western world. How to explain that?
To be honest, I don't know. I mean,
Osteomalacia also. There are many other causes of falls.
Yeah, I got that map from web, so I was not sure. Is that?
I would say that we don't know, but it's possible that data collection there's lack in data collection, and it's possible that we don't care about fall that much as they do in Western country, especially nursing homes.
How about diagnosis of Parkinson's? Is it like the? I mean, over here, like if you, I mean, I don't know. I mean, you know, how many subtle diagnoses are made, which, so what happens in our country, so it happens a lot actually in the Veterans Hospital, for example, right, where I do part of my practice. So what happens in VA, for example, in North America, is just in Cleveland, the census says that each year, we get 1,000 new patients with the diagnostic code of Parkinson. But those 1,000 patients, out of those 1,000 patients in our movement disorder clinic, I barely see 200 patients, right? So where are the other 800 patients gone, right? So would something like that happen even in India, that, you know, like there are a lot of patients who have Parkinson, but they are not into right channel, and maybe that does not give them the right diagnosis. I mean, these are the things which come from online. This is something I find on Google. I don't know how authentic that map is, of course, right? So, but I also ask myself, but osteomalacia, like Dr. Kothari said, it's a very good point. Yeah.
All right, now let's move to the question.
We are not seeing your video. Why is that?
I don't know, because I put my video on, but still.
Okay, Manasi, can you check what might be wrong with the video? Okay,
yes, I'll check.
Yeah, my video is not visible, but I'm sure that you can hear me, right?
Yes.
Okay. So coming to question from Dr. Mesra, and he's a very senior neurologist of country. How putting horizontal lines on the walking way improve the gait and falls in Parkinson disease patient? So he is talking about the lines, as we all do when the patient go to bathroom, lines, how it helps.
Yeah, so it is actually a very common strategy that we frequently use to treatment of freezing of gait, right? So it's actually, by putting the patterns on the floor, it actually improves freezing. So it's a bit of a different phenomenology. And it's another area of focus that my lab has, which is like visuo-vestibular interaction. And when there is a problem in visuo-vestibular interaction, we think it triggers freezing. And one of the ways to break freezing is to change the gate programming, right? You kind of reset the gate programming, and one of the ways to reset the gate programming is by giving a busy visual scene. So there are different strategies. So one thing is like horizontal strip you can put on the floor. In our clinics, we also sometimes give patients walkers, which has a laser beam. So every time they freeze, they kind of like throw the laser beam and they have to walk on it and they break freezing. Some people have made virtual reality goggles, which also like put a virtual lines in their view and they kind of break it. Some of my patients tell me that their wife kicks them from the back and they break their there are many things people do, like there's metronomes and all kind of things. So yeah, that is we just changed the programming. So in a simpler way, your gate circuit gets into an abnormal loop and it runs into freezing, and there is some way to break their loop, and that loop is broken by giving a visual cue. So we call it cueing.
In the same way, if I ask Aasef, that do you have any experience with 3D printing of staircase on the floor?
I'm sorry, what was that?
3D printed staircase, 3D printed staircase on the floor. There was some study on that also?
Instead of lines.
Yeah, it's just, I'm not aware of the staircase study. There are several studies which had immersive virtual, augmented virtual reality. I think this is something like that from what I can imagine. Where they have like so you know, like I don't, of course, I mean we have patients who do these things. So this is my view on all these techniques, and if you look at these studies, there's very mixed data. So some studies, so they say that like some people get better, some people don't get better. The way I view that is that, you know, whenever you provide the immersive virtual reality or augmenting virtual reality or cueing, that actually you give it after the freezing happens, right? So the key is to give cue before the fact cueing is happened or freezing is happened. So the idea is to find a pre-freezing signature somehow, and once you find a pre-freezing signature, then those cueing would be much more effective. So there are a lot of studies you will find which have mixed data, and I think it's because we are cueing after the fact. We want to cue before the fact, and that's what I was trying to do in our lab, that we are trying to find pre-freezing signature, which is very tricky to find, but we know that they exist, and we should be able to find it sometime.
Another question from Dr. Pramod Dhonde is that role of cycling in improving the balance in Parkinson's disease?
Very, very good question. So this is actually a grant that I am working on right now. So can I have 5 minutes to explain the story of cycling and Parkinson?
Right.
So there was a guy who actually works in our neighboring lab. The whole idea came from him and his friend. So, you know, there is tandem bike. I don't see, I mean, I grew up in India and I didn't see many tandem bikes in India. I do see a lot of tandem bikes in America. So what tandem bikes are like, there are two bikers, right? So one guy is in the front and one in the back. And one is, of course, riding, doing more work than the other. So this guy was actually tandem biking with his friend who had Parkinson's disease. And what happened was, we lost Rishikesh?
No, I have removed. I think Rishikesh, you got a Mac?
No, I got a Windows, but can you hear me?
Yeah, we can hear you.
Then it's fine.
Okay.
Then it's fine.
Yeah. So so one Parkinson patient and this guy, the scientist, they both went on tandem biking for fun. And then after they finished tandem biking, after they had their little hike, the guy told him that, you know, I feel much better. And that actually, that's how the whole idea of exercise biking emerged. And that now led to multi-million-dollar grant. Actually, you see that Penny and Steve Weinberg chair, the one that I got. One important thing that we are going to be doing as part of this chair is to establish an exercise program. So what we are doing now is we collaborated with electrical engineers, and they are making a smart bike. So what this smart bike is that this bike, Parkinson patients ride on that bike, and the smart bike actually detects their heart rate, their pulse, their tremor, their tone, their cadence, everything. And then it takes that information and puts into cloud, and then multiple Parkinson patient uses the smart bike, right? All that goes into cloud, and then we do little artificial intelligence algorithm, and smart bike actually challenges these patients in a different ways, and the algorithm actually fits to that patient's algorithm, patient's improvement, performance. And it's kind of like whole AI-based exercise biking. So, so we are actually working on a grant on that. So yes, exercise bike works. And if you use exercise bike in a certain way, it is much more effective than just simple exercising. But exercise in general, it works very well. I actually sometimes feel when I get flu, and if I run on treadmill, my flu gets better too. But
So, so this is something like a Peloton for Parkinson's?
Yeah, so, sort of, yeah. But it's like, yeah, it's like AI based, right? And
Yeah,
it's a
yeah,
lot
because
of
this Peloton is a company which has promoted spinning at home, and then you can select various locations. I want to go spinning now as if I'm cycling in Florida, and then it creates the whole scene, etc. So, and you
yeah,
compete
so
with
this
others.
is something like that, and it actually gets the information from people. So let's say, so every patient is different, right? So every patient's response rate is different. So what Bike does is it collects the response rate, and then it throws it up in the cloud and finds the best algorithm that worked for similar type of the response rate. It does online machine learning, and then it gives it back to the Bike, and Bike adapts to the patient.
Yeah.
And that happens in real time.
That's wonderful. I would say that for people here, that I also suggest bike, but many times I find that patients have difficulty in mounting on the bike. They have balance problem, so mounting exercise bike is difficult. So what I suggest to get only a pedal, they call as mini exerciser, 900 Indian rupees on Amazon. So, and it takes less space. Space is itself is a free, it takes less space below the sofa, and they can sit on the sofa and they can keep on doing. Only pedal.
That's very clever. I will look up for it. Yeah.
All right. Moving on. Joy Desai from Mumbai has a very nice question that what lifestyle interventions can benefit patients to ward off the need for DBS in journey of progressive balance dysfunction. So he's looking from balance angle and trying to ward off DBS as much as possible.
So I'm sorry, I did not get the DBS part. So one part of the question is what are the lifestyle
intervention that can benefit patient to delay DBS, as simple as that.
Okay, so basically delay the disease, right? Essentially.
Yeah, exactly.
Okay, so you know, the key is exercise, right? I mean, so there are two things that I tell my patients. One thing is like keep yourself as active as possible, right? Because what we have seen is people who are physically fit, they do in general better. And if they do in general better, that delays DBS, right? And the second thing is mentally fit, right? So you have to, it also is very important because that keeps you cognitively fit. Now, the right time of the DBS is actually very strategic question. It's very individualized question. And this is something I learned from Milan DeLong, who of course, many of you may know, he's the one who kind of came up with the idea of DBS, right? And Milan, you know, he was at Emory, right, Atlanta, which is hub of Delta Airlines. So he says like, we are ready when you are ready, Delta Airlines. What that means is, when to do DBS is very patient specific. To give you example, I actually with Milan, one patient we implanted who had very subtle tremor, and this was of course for essential tremor, but he had very subtle tremor, but the guy was dentist. So, you know, I mean, this is somebody who needs DBS, for day-to-day life, and those people, we are more aggressive. And then when you look at some other group of people who do not need it right away, and those people can wait. So it all matters, like who you are looking at. But of course, you want to make sure that you do your basic things first. You have to make sure that you got the diagnosis right. And typically 4 years into diagnosis is pretty reasonable time. I feel comfortable. A reasonable dose of dopaminergic medications. Yeah, I mean, as much as you can delay the disease, it's good.
Knowing Joy is a proponent of sleep and the glymphatic system. So unless you go into deep sleep, the glymphatic system does not work properly, and it has been shown to cause worsening of Alzheimer's. Possibly even impairment of sleep might worsen Parkinson's. So
It does.
yes, so promoting sleep is also important as exercise.
Oh, it's very important because when you sleep, you generate more dopamine, right? And as you generate more dopamine, when you wake up, you need less dopaminergic medications. And of course, as you all know, you take more frequent dopaminergic medication, it has its own toxic effects, right? So sleep itself, of course, it's very critical. And what I often do is, like REM sleep behavioral disorder, I make sure that that is treated because that's the #1 enemy of good night sleep. But at the same time, my younger patients, they also have a lot bad dystonia. So I give some good nighttime coverage that they don't get off dystonia at nighttime, which does not wake them up. So I make sure that I do everything possible to give them a very comfortable night's sleep. I totally believe in this.
All right, Aasef, there are at least 15 more questions. So let's try to address as much as possible, like a rapid fire way. So maybe for in next 10 minutes time. Only STN or any other site for DBS? Anonymous attendee.
Yeah, so I typically do STN when we are looking at reducing medication load. I consider GPI very seriously when they have a substantial dystonia, of course, or cognitive issues. So for Parkinson, these are the main two we focus. We rarely go into thalamus only if they have a combination with some essential tremor, but mostly we go for STN and GPI.
Perfect. Dr. Ashutosh asked that, have you tried DBS in PSP, PSP?
We do not. It's actually contraindicated.
Okay. Dr. Dhananjay asked that PPN nucleus, any role of PPN in all this?
So there are a couple of studies looking at, you're talking about pyrimidine pontine reticular formation.
Pedunculopontine.
Yes, pedunculopontine.
Pedunculopontine nucleus, yeah. So yeah, that is a major role. So my colleague had implanted and studied actually the balancing function from England, Barry Simongal. He had a paper on it. What they found is that they had some improvement, but the areas that we find in STN, which is dorsal STN, it projects into the PPN, and from PPN it goes to the cerebellum. So the way we think the STN works is it works via PPN. So, and the reason why I like STN is because then we don't have to put 2 leads. We only put 1 lead in STN and we activate PPN via STN. So that does the same thing. That's why we like STN.
That's perfect. Kishore Sethi has an important question, interesting question. That does levodopa improve eye movement as DBS does?
So yeah, that's actually a very good question. It does have some improvement in the saccades and some improvement in the gaze holding. And ocular dyskinesia, some people may know that. These are vertical involuntary eye movement. They are generated by levodopa too, but it's kind of a mixed literature on it.
Yeah. The anonymous attendee that how microsaccades improve with DBS. They're asking about mechanism.
Oh, I see. So the microsaccades, I had a slide, but we did not include that for the interest of time. The way we think microsaccades are improved is because, as you know, the problem Parkinson has is excessive noise into the basal ganglia, right? Which is hypersynchronous unnecessary activity. We still don't know how DBS really works. We are still, nobody knows, right? But what we think, it actually resets the rhythm. And by resetting the rhythm, what we are doing is we are giving less noise to the saccade generators via substantia nigra to the superior colliculus. And by doing that, we are reprogramming the entire microsaccade generating circuit. And that's how we are modulating the microsaccades.
Right. Any role of lesioning, because it's very expensive, DBS is very expensive. Any role of lesioning in eye movement improvement or balance improvement?
So there was one study that John Lee had done one patient with pallidotomy, and what he found was actually there was increase in square waves after pallidotomy. This is from what I remember from that study, but that was only one patient and that was unilateral.
There's one somewhat tough question from Dr. Anirban Biswas from Calcutta. He is neuro-otologist.
He's
And
my hero.
he is asking, in practice, we find a lot of balance disordered patients have perverted or distorted perception of motion. Perverted or distorted perception of motion, and that of balance, but no clinical sign of Parkinson's disease. What does that happen? Why does that happen? Is there any improvement in cognition after DBS? This is the second question. But let's talk about the first question first.
So, I mean, it can be because of many reasons. It's a very difficult question, of course. So, I mean, we do see distorted perception of motion in many cerebellar conditions, especially after cerebellar strokes. We do see abnormal percepts, and we think that happens because of the vestibular velocity storage, which we know is very important for eye movement. A very similar velocity storage is also there for perception, and cerebellum directly controls that. So there is one possibility that we have abnormal velocity storage for perceptual velocity storage, so to speak, and we have shown that it exists, and that velocity storage actually projects up into the thalamus. My former mentor, Dora Angelaki, showed in monkeys where the areas from fastigial nucleus, they project into the thalamus, and they're under cerebellar control. So when we have some sort of cerebellar disorder, stroke, we see that quite often. Actually, we had published a paper where people had acute cerebellar stroke. They don't come with any nystagmus, nothing. All they say is they have distorted perception, and that's quite common. And so that's one way to explain that. And DBS, of course, one of the mechanism we think ST and DBS work for Parkinson perception is via its effects on pedunculopontine nucleus. So STN to pedunculopontine to fastigial, and fastigial up to the thalamus. So that's one mechanism. And the second mechanism is this cerebellothalamic fibers, which go directly up. We are directly interacting the fibers. So it's kind of a two-way effects that we see with the DBS. And what was the question on cognition?
No, but
cognition.
one more thing, Aasef, one more reason for these patients who have impaired perception of balance despite not having Parkinson's or not having, because there are many of these patients and they do not have Parkinson's, they don't have cerebellar. Many of them probably have triple PD, so perceptual, postural, persistent dizziness.
Yeah, of course.
Which is going to cause a lot of, and they are very common patients. So it is like a final common pathway. Somebody gets BPPV, somebody has migraine, somebody has some vestibular neuritis, and then they enter into this stress plus anxiety plus everything together causing triple PD. So we will have a talk on triple PD sometime.
Just stop saying this, right? That's what he does it. Yeah. Actually, I have to say, I get myself, when I get migraine, I get really bad percept of motion. And actually, when I was in the lab, once I had them record my eye movements, they were normal. So it is a cortical, probably area MST. That's what it is.
An aura of migraine, even I get sometimes, is before I'm going to get migraine, I feel things are tilting.
Movements.
Yeah. Yep. Okay, good.
Dr. Kothari, we have 3-4 minutes.
Yes, go ahead.
We have. Okay. All right. So quick question. Dr. Jayant Pandey asked that DBS in atypical Parkinson's. Would you agree for that? Parkinson's plus disease.
No, we can't, because there are two problems. Of course, nobody's going to pay for it, and it's like $100,000 surgery. For one, nobody would let us do that. And number two, it actually makes cognition worse in atypical forms of Parkinson's. So you would probably do something worse for your patient than doing anything better. So it's not indicated.
And Srinivas asked that any role of non-invasive stimulation, TMS, on cerebellum for balance disorder.
So TMS is kind of very emerging, and a lot of people are using it for cerebellum. The problem with TMS in cerebellum is it's not very. It can create a lot of other issues. It can create pain in the muscles, and it cannot be. So for example, the areas which is for balance quite deep into the cerebellum, and it's very difficult to focally attack a particular area cerebellum with the TMS. And there's not much clinical utilities. My colleagues have done several experiments looking at saccades, looking at the vestibular function and TMS. People have looked at the transcranial magnetic stimulation of the area MTMST, but we don't have a lot of clinical application of that yet. It is still into more scientific realm. And same applies to TDCS.
Aasef, can you do one thing? There are many more questions. So if we mail them to you, you could answer them at leisure, and you could just, and we'll put them up on along with your lecture, we'll put it up on the YouTube, the answers that you give. I wanted to ask one question just before we go, that is there any analogy? I mean, can we think of Parkinson's as basically a sort of something where the person becomes rigid and inflexible? So he's rigid and inflexible in his thinking, he's rigid and inflexible in motor programs that he can choose, and now you've shown that he's rigid and inflexible in the saccades. So
it's a very good question. Yeah, I have to think about it. Yeah, I mean, it makes sense, right? I mean, they don't. So we know one thing for sure: the paradigm shifts that we normally do, they don't like to paradigm shifts, right? They have problems in doing paradigm shifts. And this is all comes down to paradigm shifts, right? Yeah. So that's a problem, right? So paradigm shifts.
Basal ganglia are involved in all sorts of flexibility like things, changing your...
Yeah, absolutely. It pitches into limbic system, right? It pitches into motor system, it pushes into oculomotor system. So what we are, I mean, you know, there is more than one person's career worth of work. All we know right now with DBS is tremor and tone, right? There is an oculomotor STN. So Milan, every time I talk to him, he tells me something which I never read in the book. So Milan once told me that in monkeys, he found some eye movement sensitivity in STN. And I said, why didn't you ever tell me before? So, you know, there are areas in STN which are responsive to eye movement, but if we don't find that in literature. So there's a lot of things that is there to explore in this area.
Okay, thank you for the scintillating talk. I mean, it was wonderfully done. Thank you, Rishikesh.
Thank you very much.
I'm sorry we couldn't get your video on the screen, but
no problem.
Your voice is distinctive enough. Everybody knows who it is. So thank you, and we look forward to the next talks. Bye, and have a good day.
Wonderful.
Bye.
Thank you, Aasef. Aasef, can you have we have your email ID? So somebody, if they have to ask questions, they can ask you if you want my call.
Sure, they are more than welcome to send me a note, and I'll be happy to answer right away. And it should be at the beginning of the talk.
Fine.
On the front title.
All right.
Thanks. Yeah.
Okay.
All right.
Bye.
Thank you. Bye bye.